Much, Jason. And it's great to be able to speak with you today, colleagues from Saskatchewan, on this critical issue. Nick will be advancing the slides for us. Before getting into this, of course, we're all concerned about antimicrobial resistance as a slow-moving but very serious wave of emerging infectious disease. And we're all trying to address that through better surveillance, better infection prevention and IPC in our facilities, better innovation of new drugs. But this role of stewardship in reducing the force of natural selection for resistance is critical across human and animal populations. And while we will focus on the 90% of human use, which is the subject of community stewardship efforts, I want to acknowledge the importance of the efforts going on in hospitals and agriculture today. And as we heard, yeah, do bugs need drugs is an element that we share with Alberta and are happy to broaden the Western Consortium in the area. But we want to speak about the areas we know best in terms of the efforts in BC and where they've gone. Nick, would you advance? So Nick and I are joining you from the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations, collectively known as the Coast Salish, because they share a common tongue. And as we sort of get into the summer on the coast here, and you begin to see how interesting the land is, you realize how much a matter of perspective it is. I was reading the diary of George Vancouver recently, and the guy was a superlative mariner, but his attitude was terrible. He'd get to the end of an inlet, which had glorious stuff on the end, but because he didn't find his connection to the Northwest Passage, he was disconsolate and named things Desolation Sound and things. So attitude is everything. And what we'll do today is go to the next slide. We're going to break this talk down in terms of a few elements. We'll talk about antimicrobial resistance and community stewardship and its role. We'll give you a bit of history in terms of our program background. We'll tell you about some key examples of activities and outcomes that we've been able to measure. And then we'll discuss some of the main interface we have with primary care. And finally, because I think there are some decision makers there, I think we have an overwhelming business case for public investment in community stewardship, and you'll hear that from us as well. And we can end with some discussions and questions. So I believe, Nick, it's over to you to introduce us.
Thanks, David. So we thought we'd just start by setting the stage, and I'm sure this isn't new to most folks on this call, but the toll of antibiotic resistance, this isn't a future problem. It's something that we're faced with today, with approximately 5,400 Canadians dying each year due to drug-resistant infections. Globally, 1 in every 100 deaths are due to resistant infections, and we could see, estimates of up to 10 million deaths worldwide if no action is taken by 2050. And here in Canada, the healthcare system costs are about $1.4 billion every year. On the right there, this continues to be a concern in community settings as well. The estimates suggest between 30 and 50% of antibiotic prescriptions written in Canada are unnecessary and are mostly for, there's those viral upper respiratory tract infections, UTIs, and mild earaches in kids, all of which are primarily being prescribed for in community settings. And so when we talk about antibiotic stewardship, I'm sure most will know that it aims to measure and improve how antibiotics are prescribed and used. And traditionally, most stewardship has focused on hospital and agricultural settings. But we know that 80 to 90% of antibiotic prescribing occurs and antibiotic use occurs in the community. And so for that reason, community stewardship is vitally important as well. And community stewardship focuses on improving the use of antibiotics in outpatient settings, so with GP clinics, community pharmacies, dental offices, and other community settings like that. And antibiotic-wise and Do Bugs Need Drugs are community stewardship programs that we have here in BC. I'll talk a little bit more about them, but they include public and prescriber outreach and education, monitoring, research, and more. So a bit of background about our program. Do Bugs Need Drugs was founded in Alberta in 1998 by our colleague, Dr. Edith Blondell-Hill. and was imported to BC with the help of David in 2005, where we continue to operate to this day, situated within the BC Centre for Disease Control. Antibiotic-wise is a website that launched in 2015 as kind of the main online portal for public information about antibiotics and AMR here in BC. And so when we talk about Debugs New Drugs and Antibiotic-wise, we use kind of both brands here in BC. Debugs New Drugs mainly kind of on the public education side of things, and Antibiotic-wise for our outreach and awareness. Now, when the program first started, it focused primarily on public education as well as surveillance, but over the years has grown to include a lot of outreach and awareness and engagement of public audiences, as well as a real focus these days on professional outreach and education, and providing tools and resources for prescribers in community settings. And our surveillance program has also expanded to be a more robust overall research program. This slide, it might be kind of hard to see with all the small text, but this is the logic model that guides our program kind of on a multi-year schedule. A few things I want to highlight. Under resources, I mentioned that we are embedded within the BC Centre for Disease Control, BC's public health agency here in the province, which is very useful for connection and collaboration with colleagues. And we're also grateful for the funding that we received from the BC Ministry of Health to operate our program. I mentioned most of the activities that we're focused on, and in terms of outcomes, we're looking to increase knowledge and change behaviors of both public and professional audiences. And the long-term impacts we are kind of threefold that we're looking to make a dent in or make a difference in. One would be the reduction in unnecessary prescribing of antibiotics in the province. The second is a reduction or at least a stabilization of antimicrobial resistance in community pathogens. And the third is a reduction in morbidity associated with antibiotic use in BC. So this is about reducing adverse events or side effects of antibiotic use, as well as decreased incidence of things like childhood asthma and atopic disease, which, as we'll talk a little bit about in this presentation, we're seeing an increased connection between decreased infant antibiotic use and incidence of asthma here in the province. So with that, David, I'll turn it back over to you to talk a little bit about some of our program activities as well as the associated outcomes.
That'll be good. So when you try to connect the dots here, if you go to sort of the global literature, you'll see around the world that where there are more antibiotics in use in human and animal populations or in agriculture, you find resistance determinants more frequently. And of course, this isn't just in the pathogens that we're chasing. We're not just worried about selecting for resistance in a pathogen that we might currently be treating. It's in everything else in our flora and in our environment that might get exposed to the selective effect of those antibiotics. So I just thought I'd tell a few stories that have happened over the course of the program. We have done our best while delivering a population health program in a non-randomized way to use interrupted time series and causal inference to sort of take a look at some of the effects of what's been going on. Naturally, when we launched the program in 2005, the big concern was overuse for respiratory tract infections. Nick mentioned otitis media, bronchitis, for example. And so there was a big push on in terms of both the public awareness, do the sorts of messages like, coughs and colds and flus aren't benefited by antibiotics, that sort of thing, but also the promotion of the guidance to clinicians. And so next slide, Nick. What I'd like you to notice is it certainly takes a while before you begin to see any important deflection. And so this is my beef, folks, when people say, hey, why don't we just have a campaign, a one-off campaign, get the government to pay for a campaign this year. I don't think a single campaign does squat. I think constant messaging and programmatic effort over time are what's required to steer this very, very big ship away. And so what we can see here is we saw, quite a dramatic drop in respiratory tract specific prescriptions over the course of the program. Naturally, the dip in 2020 is an artifact of the pandemic, so we don't take credit for that one. But improvement going down here, and lots of other things going on in the environment as well at the same time, expanded immunization programs, other forms of promotion of guidance and that kind of thing. So that was respiratory tract infections. But then we maintained surveillance, and it became obvious to us that we were actually seeing increasing use for urinary tract infections, much of it in the elderly. And when you dug around and went to focus groups, it was clear that a lot of this problem was also the treatment of asymptomatic bacteriuria in long-term care facilities and other places, and in outpatient elderly. So then we turned our attention to UTIs. We naturally wanted to make sure that guidance on diagnosis and management of UTIs was well observed. We busily worked with the AMI Canada program, the Symptom-Free P Let It Be campaign. We had portraits going out to physicians to encourage their selection of nitrofurantoin for uncomplicated cystitis, compared to the previously heavily promoted fluoroquinolones and trimethoprim sulfa, to which we were seeing more resistance. So that was an effort that was happening sort of early mid 2010s. Nick? And again, we began to sort of push on this, and I would say it took a couple of years before we began to see change, and we'd like to see a little bit more. But these sort of UTI-coded prescriptions in the population have dropped to a certain degree. But we're going to need to sort of revisit what else needs to happen over time, particularly with changing microbiology in UTI. And then, the other thing that was going on is we were taking a look and saying, hey, these physician-specific prescriptions are going down quite a bit, but our overall prescribing in BC was not going down as much as we expected it might. And that's because we discovered, to a certain extent, we were playing whack-a-mole. We were focusing on the physicians. And meanwhile, there was an increase in prescribing by dentists. A lot of it was sort of perioperative prophylaxis prescribing, or perhaps overprescribing for periodontal abscesses that could have been drained rather than treated with antibiotics. So we then had to engage with our colleagues in the dental profession to sort of emphasize the opportunities in the new guidelines to reduce the use of antibiotics prophylactically around surgery, when they are indicated, to remind people that it's not a 7-day course, it's a perioperative dose that's recommended, and also to sort of take a look at other indications and how things could be improved over time. So that meant publications for the dentists. It meant that we were quite concerned, for example, about their use of clindamycin in high amounts. So we gave them some flow charts to help them work through this question of beta-lactam allergy delabeling and when they could safely move away from it. And then let's have your picture there, Nick, the next thing. And so, yeah, we'd seen this big increase in dental prescribing, and now we've been able to sort of observe that it's coming down a little bit. Again, we're taking no credit for what happened in 2010, although we did observe overall not much of a decline in antibiotic use by dentistry, because dentists who couldn't open surgery to drain that abscess were sometimes temporizing with antibiotics. But again, it took time, and it takes time for this to happen. So this isn't a campaign. It's a program, is I guess what I would say are the main elements for us to remember. So, what are the sorts of things, if we have a continuing education effort for physicians or for nurse practitioners or for other prescribers? The messages, I think, are very straightforward when we're speaking with primary care. I think you have a more complex problem in the hospital when you're dealing with more complicated systemic infections. But very frequently, we just put them all on one slide just to illustrate, hey, if you have this on your wall and you're able to work towards this, you're doing your part. And there are observations like streptococcal pharyngitis. If you have to wait for a culture before you decide to treat it, you don't see an increase in scarlet fever or rheumatic fever. And if you are treating it, you can stay narrow spectrum with Pen V because it works fine. We've emphasized, of course, for a long time that otitis media improves in 24 hours on analgesics alone, a lot of the time, and only after that do we tend to resort to antibiotics. We've continued to try to avoid the treatment of acute bronchitis with antibiotics, although I must say that remains a very frequent billing code associated with antibiotic prescriptions, so we've still got work to do there. Ditto for sinusitis. I think a lot of the time we're realizing that the vast majority of cases of sinusitis are going to resolve with symptomatic treatment and with nasal rinses, and don't necessarily need antibiotic treatment. We've tried to do some counter detailing. We've known a lot of drug companies have tried to push their respiratory fluoroquinolones and other things for acute exacerbations of COPD and pneumonia, but the evidence-based guidance speaks to their use only rarely. So we've been emphasizing the use of first-line agents for community-acquired pneumonia and acute exacerbations of COPD. We did mention we've been emphasizing the use of nitrofurantoin for uncomplicated cystitis. Fosfomycin's a good drug too, but if you're working in the hospital, you're hoping that we don't select for too much fosfomycin resistance in the community because it's a good rescue drug for difficult infections. We are avoiding the treatment of asymptomatic bacteriuria, except in pregnancy, and even that needs to be reevaluated. We're avoiding overuse of non-specific dipsticks or treatment on the basis of culture alone in the elderly, making it a UTI, a diagnosis that requires localizing symptoms. We're avoiding the prescription of antibiotics after IND of uncomplicated skin abscesses. So this is exactly the same as the periodontal abscesses for the dentist. And we're avoiding using second-line antimicrobials for patients reporting non-severe reactions to penicillin when beta-lactams are the recommended first-line therapy. We don't have time to get into that in too much detail, but as you know, the cross-reactivity is based not on the beta-lactam ring, but on the side chain for the beta-lactam molecule. And while you have a similar side chain between amoxicillin and cephalexin, cefuroxime has a different side chain. And of course, we're very keen on the folks in medical profession and pharmacy helping dental colleagues adapt their guidance. It's actually quite a revolution because there are very few remaining indications for antibiotics perioperatively in dentistry, but people haven't learned that way, and they're often worried about bringing about a medical complication that you will have to deal with. So they need to be reinforced. We need our orthopedic surgeons and so forth to say to the dentist, hey, it's okay. Joint infection, joint replacement does not require perioperative antibiotic. Next. And then finally, you may be familiar with it, but we try and form a repository of advice that is coming from North American guidelines at bugsanddrugs.org. That process, which is led by Alberta, but we collaborate with it, involves no industry involvement. We make sure, and I don't know if it's true of Saskatchewan, but if you have an EARL in Alberta and BC, you've got free access to the up-to-date guidance. And the guidance differs from what you may see in the Sanford Guide and other sources in emphasizing first-line agents when treatment's required and symptomatic relief when it is not. And we try to support that through continuing education and journals. And that's just a screenshot of the website. And next, we're going to change tune, and Nick will sort of talk you through what I think is a really interesting way of thinking about this. If you don't have a community stewardship program in Saskatchewan today, and your Minister of Health would understand that it could both be good for health and save money, maybe that will change your likelihood of getting funding. So Nick, if you could talk us through it.
Thanks, David. Yes, so it's great to talk about our program and a little bit of the work that we've done, and we're obviously very biased around our support for the program, and so part of what we want to do is also advocate for others to do similar programs across Canada and around the world as well. And so I'm just going to talk through a few of the the setting the stage for a business case for the program. And as David mentioned, the first piece of that is around cost and cost savings. We know from our program and from Alberta's Do Bugs Need Drugs program as well that program costs on a per capita basis are quite low, and certainly at least on the higher end can show considerable return on investment. This graphic here shows details from some research that our program undertook a few years ago now that found that between the years 2005 and 2014, the program saved nearly $450 million in terms of the cost of antibiotics. In 2014 alone, that number was about $84 million in savings, with a third of that being savings toward government through decreased cost of pharmacare, and about 2/3 savings in terms of direct patient costs, or at least their third-party health benefits providers. And what this represents is a savings of $76 for every $1 spent on program activities. And so what we really like about this program and what this shows is that it's a rare kind of win-win for healthcare in which we are improving patient outcomes while also reducing healthcare spending. Now, the other piece of making a case for community stewardship is around preventing the harms associated with antibiotics. So there's a few things that I'll discuss. The first being allergies. As we all know, antibiotics can cause allergic reactions, including some severe reactions. And I think this sentence down here, I don't know if you can see my cursor, but these reactions are preventable in every case where unneeded antibiotics are used. And so that's really the crux of it, trying to reduce that unnecessary prescribing of antibiotics. And while allergies are fairly rare, it's important to know that things that aren't true allergies, side effects of antibiotics sometimes get labeled as allergies, which can lead to, cases where individuals are not being prescribed first-line antibiotics like penicillin when they may actually be safely able to take it. The next harm that we're trying to prevent is C. difficile infection. Even though it's an opportunistic bacterial infection following antibiotic use. And we have key strategies for reducing C. difficile infection that are infection prevention and control, but also when an antibiotic is needed, ensuring that the narrowest spectrum option is recommended. And of course, trying to ensure that the shortest course of therapy is prescribed as guidelines dictate. This has been one of the major focuses of our messaging to dentists here in BC. Clindamycin is used quite extensively still within dental practice in BC and has quite a high risk of C. difficile infection. So it's been one of the key drivers of our work with dentists in the province. And then asthma. So there's growing evidence that reducing antibiotic use in infancy can reduce childhood asthma. These results are from an ecological study that we undertook a few years ago, but there's more recent evidence coming. Our colleague here in BC, Dr. Hannah Lishman, is undertaking a large retrospective cohort study right now that is showing some strong early results that kind of correlate with these findings here. And she's collaborating with folks in Manitoba as well. So be on the lookout for results of that as we begin to look to publish them over the next year. But what we can say is that there appears to be a connection between reduced antibiotic use in infancy and a decreased incidence of childhood asthma rates. And you can see on the right there kind of the suggested causal pathway of how that happens.
Nick, if I just may, this isn't based on ecological evidence alone. Obviously, we first became aware of this dramatic decline in childhood asthma following the fall and an equally dramatic decline in antibiotic use in babies. And so that's, correlation is not causation. But then we went to work with the child cohort, which is a multi-center cohort in Canada, showed the same effect at the individual level, that antibiotic exposure in infancy more than doubles your risk And if you're antibiotic exposed in infancy and not breastfed, your risk is more than tripled, because the interesting thing is that breast milk actually works in a favorable way against the microbiota. But we've been able to look at the microbiota effects in those same kids because we have nappies from 3 months and 12 months. So we're basically seeing a story of antibiotics damaging the normal development of the microbiota. There are missing taxa that normally interact with the developing immune system to reduce the risk of atopic responses. And so the bottom line from a public health point of view is if you can avoid unnecessary antibiotic use and promote breastfeeding, you're doing a lot to reduce the burden of illness from asthma. And we're talking about a serious reduction in burden of illness from asthma.
Perfect. Thanks, David. And so, the question comes up, of course, is it safe to decrease antibiotic prescribing? We can use surveillance data to detect problems in terms of, if we're swinging the pendulum too far and there's an underprescribing of antibiotics when they are needed to treat bacterial infections. We have, in fact, done some preliminary studies to show that the rates of severe bacterial infections in children under 5 has remained stable or actually decreased over the length of our program here in BC, suggesting that we haven't swung that pendulum too far, and most of the reduction that we've seen in antibiotic prescribing was in fact unnecessary antibiotic prescribing. But certainly it's a key part of our program that we want to be the first to detect if that is a concern. But plenty of evidence from around the world shows that we probably still have a ways to go before that becomes an issue. And David, I'll turn it back over to you now to kind of put a nice bow on it.
So just to summarize, folks, because we'd love to get into a discussion with you, what we're finding is that community stewardship appears to be working to reduce unnecessary antibiotic use, and we've certainly started from a middle of the road thing in BC to being the lowest using province in the country right now. We're also alongside that seeing the robust cost savings that are happening along with this, and that's why our branch of the Ministry of Health that pays for pharmaceutical billings, they've been more than happy to pay for this service because they're seeing the cost savings associated with it after a few years, mind you. And so the principles that we are continuing to push for antibiotic stewardship are preserve antibiotics for future generations, make sure 2050 is not a nightmare time for bacterial infection, preserve the effectiveness of new antibiotics, make sure they don't get overused, avoid wasting healthcare resources, but above all, also avoid unnecessary harm from antibiotic use. And I think we're learning a lot more than it just being the odd case of urticaria, that like every other pharmaceutical we use, there can be adverse effects. Go on, Nick. So in conclusion, most antibiotic prescribing occurs outside of the hospital in community settings, which is why we resolved that we needed to have a program to focus on those settings. Existing community stewardship programs are cost effective, even when considering drug costs alone. We haven't even factored in the cost of averted complications. Both potential harms and benefits need to be considered when deciding to prescribe antibiotics. So you have to know when to put the brakes on. If we suddenly saw a big increase in rheumatic fever or mastoiditis, for example, we'd know, oh, maybe we've gone too far in reducing antibiotic use, but we've not seen those yet. And implementing community antibiotic stewardship as a program, not as a campaign, is a necessary investment to protect antibiotics as a resource, in our opinion. Next slide. So we know this is question and answer for you folks, but we're also very interested, just in prompting that discussion by saying, what's the current state of community stewardship in Saskatchewan? Where do you want to go from here as a province and a neighbor? And what's the appetite for community stewardship from the Ministry of Health, which really is the natural payer because they're the beneficiary of the savings. So we'll stop there. We got a few references and we'll throw up the question slide, but we can also drop the presentation if it helps see people.
Yeah, that's great. Thanks, guys. I'm just going to stop recording.